Awesome. Well, I can't see everybody, so it's a little weird to just be looking at myself, but I'm Dr. Jenkins. I'm at KU. I work in the Department of Psychiatry and Behavioral Sciences. So like Sarah said, I'm the neuro rehab psychology postdoctoral fellow. And basically what that means is I have my PhD in psychology, and I'm specializing in neurorehabilitation or rehab psych. And what that means is I am doing inpatient consults here at KU Med, and I primarily go to the physical medicine and rehab units, the burn units, the trauma units, and the surgery units. And for the physical medicine and rehab units, there's lots of folks who have had a stroke on that unit. There's lots of folks who have had a traumatic brain injury or maybe a spinal cord injury on the unit. So a lot of the patients that I've seen after they've had a stroke of some kind are over on that unit. And I'll speak a little bit in some of my experiences I've had with some folks over there. So I do also want to add a little bit that with my slides, I have used some of the slides from Dr. Nia Billings, who was the postdoc last year. So I want to give her a shout out and some credit to a couple of the slides that I have utilized from her presentation. So I just wanted to say that. Let's see, okay. Whoop. Let's see, there we go, okay. So for just as an overview for what I'm gonna go over today, I'm gonna review the different types of stroke as well as the etiology of those different types of strokes. And then I'll talk about the prevalence and some public health significance from these strokes and what that means for the community. I'll review some risk factors, some symptoms, different psychological concerns. I'll be focusing mostly on depression, but I do want to put a caveat that there are other psychology or psychological concerns that folks might have after a stroke. And then I'll talk about some of the treatments. And I added a slide at the very end that also kind of talks about how to support folks or stroke survivors who are also having to deal with COVID at the same time. So I talk really fast. I'm going to try and slow down my rate of speech. I also want to let y'all know that these slides are very word heavy, and I'm not going to read everything word for word, but I do plan on sharing the slides with Sarah, and she'll eventually share it with everybody. So you know, if I'm going too fast or anything, just know that you'll have access to all of this stuff either later today or maybe tomorrow. So I apologize if I seem like I'm going kind of fast, but I'm trying to slow down. So, all right, so the first stroke I want to talk about is a hemorrhagic stroke. And I use a lot of the images from the stroke.org website because I love how big they are and how they kind of zone in on different areas of the brain to show what different strokes are like. So for hemorrhagic stroke, this can either be a brain aneurysm burst, like a brain bleed, or a weakened blood vessel leak of some kind. So there's two types. There is a intracerebral hemorrhagic stroke or a subarachnoid stroke. And I'll talk about the subarachnoid one here in a second. The etiology of this kind of stroke is where blood spills into or around the brain, and it creates a lot of swelling and pressure, and this can then damage the brain cells and tissues around that. So you can see in the photo that the blood vessel itself has swollen and then it's burst, and that's where you have the bleed. This is a less common stroke. It's about 15% of all strokes, but it does have a 40% rate of or percent of stroke deaths. So it isn't good, but it is less common. For an intracerebral hemorrhagic stroke, this is when, again, it's a brain blood vessel burst and it leaks into the surrounding areas. You can see, again, kind of how the blood vessel has, it's a normal kind of length, and then it'll bulge at one point and then it'll burst. Some of the causes from this are either due to hypertension or if it's an aging blood vessel itself. It can also be due to what's called arteriovenous malformation, which is a genetic condition. And this is when there's abnormal connections between arteries and veins, and this occurs mostly in the spine and the brain. If this is caught early, it can be treated pretty well. So it is something that, you know, if you can do genetic testing or you can find this, then it can be treated. But one of the most common types is due to hypertension. For a subarachnoid hemorrhagic stroke, you have space between your brain and your skull, and there is extra fluid in that space. So that's your subarachnoid space. And so when you have a subarachnoid hemorrhagic stroke, there's bleeding in the areas between your brain and the tissue that covers that brain. So when there's extra bleeding in that area, it causes other arteries around that space to start to spasm. So if you look a little closely at this photo here, it kind of zeroes in on what that space looks like. And so the subarachnoid space is there in the blue. And when you have a bleed, it bleeds out into that area. And then that's where you can have the arteries to spasm. So some of the causes from this are, again, a burst aneurysm, the malformation, that's the genetic condition, different bleeding disorders, a head injury of some kind, or blood thinners. So sometimes I've seen this in folks who have been in a car accident, and they've taken on heavy head trauma to a certain area of their skull, and they'll have a kind of a brain bleed in that subarachnoid space. Let's see here. And then an ischemic stroke is, so a hemorrhagic stroke is where you have a brain bleed of some kind. An ischemic stroke is where you have a blood clot. So when you have a blood clot in a blood vessel that carries blood to the brain is then deprived of blood. And so there's two types of ischemic stroke. There's embolic and there's thrombotic. And most of these are caused by hypertension, and these are fairly common. It's 87% of strokes. And so you can see in this photo here that if you have like a clot, for example, in your heart that travels up to your brain, you can see how the clot then can take over the whole blood vessel, and then the rest of that blood vessel doesn't get any blood to that area of the brain, and that's where you can have some brain damage. So the two types of ischemic stroke, like I said, are embolic or thrombotic. So embolic can come from, like I said, the heart. It can also come from the lungs, for example, sometimes even the leg. And it travels up to the brain, and it blocks a small blood vessel that then, like I said, blocks the blood getting to that part of the brain. And it's also fairly common in folks who have atrial fibrillation. So then when you have a thrombotic ischemic stroke, excuse me, that's my pager going off from the inpatient unit. Let me just cancel that page. When you have a thrombotic stroke, it is when you have a blood clot that forms inside an artery that then supplies that blood to the brain. And there's two types. There's a large vessel or a small vessel thrombosis. Large vessels thrombosis are more common. This occurs in the brain's larger arteries, whereas a small vein or small vessel thrombosis occurs in the small artery vessels of the brain. So for large vessels, some of the causes are due to either atherosclerosis, when you have rapid blood clot formation, or high cholesterol. Some causes, though, for the small vessel thrombosis is either hypertension, and also research is limited in terms of what other causes could be due to the small vessel thrombosis. That was a lot of information. I'm really, really sorry if that was really fast. Then you have something called a transient ischemic attack, or a TIA. And this is something that mimics stroke symptoms, but isn't a stroke. So it can last less than 24 hours and then disappear. It may not cause permanent brain damage. However, it can be a warning sign that a stroke may happen. So 40% of people with a TIA will have a stroke after they have their TIA. So when I've had patients before who have mentioned that they had a TIA, we monitor it closely to do stroke prevention type treatments, because we try to not have a stroke occur down the line. When folks do have a stroke that occur after a TIA, it's in about 50% of folks. So the etiology of this is when there's low blood flow in a narrow part of a major artery, such as like the carotid artery. It could also be due to an embolus, and then it could also be due to like a narrowing of a smaller blood vessel in the brain. So if a blood vessel narrows or gets smaller, then it's easier for a clot to form, or it's easier for it to become blocked in some way. And this can be caused by like plaque. It can be caused by, like I said, a blood clot from something like your heart, your lung, or your leg. And then I guess if you want to look at this photo here, you can see that there is the carotid artery, and then you have your cerebral artery. And you can see that like when you have a major blood artery to the brain, if that one becomes blocked, it's something kind of like a TIA. So what is the public health significance of this, or what are the rates of this? So when I look at some of the stats, nearly 800,000 people experience a new or recurrent stroke each year. And research shows that about every 40 seconds a stroke can occur. It is the 5th leading cause of death in the United States, and every 4 minutes someone unfortunately passes away from a stroke. They can be prevented. Up to 80% of strokes can be prevented, and it can cause different forms of disability in patients after they've had a stroke, and I'll talk about that a little bit later. I also broke down in terms of, I have extra information on this if folks want more detailed information by demographics, but I did break it down a little bit by groups by male and female. So for females, it is the 3rd leading cause of death. It kills twice the times more than breast cancer. It's the 5th leading cause of death for men, and the risk for stroke is the greatest for the first year of life, or for women right before or after they give birth. Stroke is in the top 10 causes of death in children, unfortunately, and boys and African-American children are at the highest risk for stroke compared to other groups. So I do have extra information, not in this PowerPoint, but if folks want me to add it, I can. That talks about how stroke impacts different demographic or ethnic cultural groups. So I have it by like folks from Asian cultures, folks from Native American cultures, and African American cultures. So if that's something people want added to the slides, let me know at the end, and I can add that to the PowerPoint then to send to Sarah. But there are differences amongst different ethnicities and races. So if I do want to acknowledge that there are some health disparities when it comes to rates of stroke. What are some of the risk factors for stroke? I like this image here because it kind of breaks down exactly all the different kinds, and what I like the images because it kind of shows what it looks like. So, excuse me, some of the risk factors are like family history, genetics, for example, like if you have a family history of heart conditions or high blood pressure, for example, if you have carotid artery disease, so that's the narrowing of the carotid arteries. Like I said, hypertension, atherosclerosis, which is when plaque builds up in the in areas of the heart. Atrial fibrillation, this can weaken the heart and can lead to heart failure over time if it's not untreated. High cholesterol is another big risk factor, as well as diabetes. Smoking, this can double the risk of stroke. It increases clot formation, it thickens up the blood, it increases the amount of plaque buildup. I've also noticed too that people who use a form of stimulant, recreational drugs, will have a higher increased rate of stroke. So my patients who have a history of methamphetamine use of some kind will sometimes maybe induce a stroke later on. Other risk factors include lack of exercise and being overweight. So your diet and how much exercise you're getting, because the more exercise you're getting, the better heart health you have, the better blood sugar and blood pressure that you have. So the more that you exercise and eat right, the less risk of stroke. So I like, some of these images here, having high blood pressure, hormonal contraceptives can be a risk factor sometimes. Let's see what else is in here. Substance misuse, like I said, some of the methamphetamine or other stimulants like cocaine, for example, binge drinking, so drinking a lot of alcohol in a really short amount of time. I talked about smoking. This also goes for, this is a little old, this is from 2017, but vaping as well. So vaping has been a lot more common in probably the last 5 years. Previous stroke or a previous TIA is a risk factor. Increase in age, like I said, family history or ethnicity because of genetic background. And then the rest I kind of talked about. But I like this image because it kind of highlights what areas to consider and then how to kind of think about each section. So what are the symptoms of stroke? I think I saw Sarah's image before and it had be fast. The FAST exam is really good to kind of consider when you're thinking about what are the risk factors for stroke. So stroke happens very, very, very fast, right? So when you have a sudden weakness or numbness in a certain part of your body, and it typically happens on one side of the body. So sometimes if we see folks, I've sometimes get consulted down to the emergency department, and if you ask them to, I don't know if you can see me back here, but if you ask them to raise their hands and one lowers, that is a sign that you have weakness on one side of the body. Or you can ask them to smile, for example, and if one side is smiling upwards and the other one doesn't really move, that's also another sign. If there's sudden confusion, difficulty speaking or understanding. So a lot of my folks who have had a stroke will be able to comprehend the conversations going on around them, but they're not able to get the words out. So sometimes the words are what I would call a word salad. So they are like flower, boy, pad, like they're words, but they don't mean anything in syntax form or contextual form. Or sometimes folks will try to speak and they don't come out as actual words. Another sign is trouble, suddenly having trouble seeing in one or both of both eyes. And sometimes that can be total vision or it can be a particular side. So there can be like left visual neglect or right visual neglect. And that's when folks have a hard time attuning to a particular side of their spatial awareness. Another one that deals with motor ability is sudden trouble walking, dizziness, loss of balance or coordination. So if folks are sometimes they'll come into the emergency department having had a stroke, but they also fell due to their stroke, and they might have other maybe head trauma or trauma to a limb because they lost the coordination was difficult. And typically, again, that happens to a particular side of the body. And then lastly, one of the symptoms is a sudden severe headache with no known cause. So when I've talked to patients before about what that headache or what that pain feels like, it typically, or what they've told me is that it's like the most painful headache they've ever had in their entire life, and it just doesn't let up. And that can be a sign, like I said, of a stroke or something like a brain aneurysm, like a brain bleed. So if it's really fast and it's really sudden, you want to get people to the hospital really quickly. In terms of treatment for that, there's a magic window in terms of how fast we can get folks to the hospital and get treatment. And if we can get in that magic window, there's different interventions that the physicians can do to help maybe counteract a stroke. So that's why it's really important, if you notice some of these signs, to get people to the hospital as quickly as possible. Let's see, some of the psychological concerns that I want to kind of get into are going to be adjustment disorder, major depressive disorder, and post-stroke depression. But I wanted to start off everything by saying when it comes to adapting after a stroke, having a stroke is, I would consider, a life-altering experience, and it's understandable that folks will worry about what their future looks like, especially if they, what their life plans are at whatever stage of life they're in. I've had patients with a stroke that are in their 20s. I've had patients with a stroke that were in their 80s. And, some people are, maybe in the midst of school and about to graduate, or they're in the middle of their career, or they're a parent, they might be a young parent of young kids. There's a lot of things that, whatever roles or whatever stage of life they're in, it can be really scary when you've had a scary medical condition happen, but then also there might be some, physical effects that might change or prevent how you move forward with different goals that you have, in terms of like going back to work or being able to drive again, or what will parenting look like, things like that. So it makes sense that folks tend to worry about those things. Some stroke survivors also talk about feeling maybe a loss of their former self, especially if they put a lot of their identity in, the type of work they do or the role they are as, like, a spouse or a parent or a caregiver of some kind. And so if they feel like they're not able to do the job that they were once doing as well, they kind of feel like some of their identity has changed. Folks also might feel a sense of diminished self-worth along with those things because they may not feel like they're achieving as much. They lose trust in some of their own abilities. Some of my patients have talked about how when it comes to relationship and caregiver factors in terms of like with their spouse, they'll talk about how they're they go from maybe being husband and wife to patient and caregiver, and how that kind of bleeds into changes in their relationship, as well as changes to maybe their like their sexual desire moving forward. So for example, a stroke survivor might have like a reduced sexual drive right after the stroke, but then, you know, some of that sex drive might come back in time and they want to have sex with their partner, and that partner is such in the caregiver role that that they're worried about moving forward in that kind of stage of their relationship as well. So it's not only necessarily in the caregiver dynamic, but it can move into different areas of relationships. Age at stroke was also found to predict different psychological and social functions after the stroke. So brain plasticity is when if you've had damage to a certain part of the brain, your brain can compensate for some of those damages. So this is a really extreme case, but there's been cases of when people have had portions of their brain removed, the other parts of the brain compensate for what that portion used to do. So for example, there was a case, I believe, of like a 7-year-old girl who had one whole hemisphere removed, and her other hemisphere didn't compensate 100% for that other side that was removed, but compensated a lot for what that one side did. So the younger you are, if something happens, the more time you have for brain plasticity. But the brain, I think, I'm biased because this is my field, but I think the brain is one of the coolest things because it's able to adapt to sometimes different trauma that's happened to it. So when children have had a stroke, the brain plasticity in children will help children sometimes compensate, and they may not have as many difficulties versus maybe an adult or an older individual who had the same kind of stroke, just because their brain is so young. And then another research finding was that psychological function at 12 months post-stroke was a significant predictor of function at 5 years down the line. So how someone is a year after their stroke can really predict, you know, how they're doing even further down the line in terms of their mental health. So if folks are having a hard time with anxiety or depression, for example, 1 year after stroke, and if it goes maybe untreated, that can linger for a lot longer and maybe even worsen over time. So I wanted to throw that statistic in, or research finding in there. So the first thing I wanted to talk about was adjustment disorder. And adjustment disorder in our DSM, which is the Diagnostic and Statistical Manual for Mental Disorders, can be adjustment disorder with depressed mood, it can be adjustment disorder with anxious mood, or it can be adjustment disorder with mixed anxious mood and depression. I'm going to focus more on the depression side, but just know that there can be anxiety in there as well. So adjustment disorder is when there's an emotional behavioral symptoms that develop in response to some sort of stressor that happened within a 3-month time period. So in this case, it would definitely be something like a stroke. Sorry, that's my pager again. That's what happens when you're doing inpatient consults. So a stroke would be an example of this. Another stressor could be something like someone in your family or a loved one has passed away, like a spouse, for example, or even sometimes a dog. I consider pets as a part of your family as well. Or something like job loss or divorce, if there's or maybe a new medical diagnosis, like a cancer diagnosis, for example. Those are all stressors, right? So if folks feel distressed after that, or if they've had some sort of significant impairment in either their social life, their job situation, or other areas of functioning, like being able to get up out of bed every day, or like maintain their hygiene, those would be where like I would start to become concerned. Another sign of adjustment disorder is if there's a stress-related disturbance that's not exacerbated by a pre-existing mental disorder. So that means, if you didn't have any mental health diagnoses before your stroke. So it would look different if someone had a major depressive disorder, for example, 10 years before their stroke, or before their stressor. If the symptoms that people are presenting with do not represent normal bereavement, that would be more of an adjustment disorder. And it would also be adjustment disorder if once that stressor is removed, the symptoms don't persist longer than an additional 6 months. So, for folks who maybe have had lost a spouse, for example, if after a certain length of time, if after maybe 6 months or 9 months, some of the depression symptoms have decreased, then it would fit more of like a adjustment disorder with depressed mood, versus something where if it lingers longer past that, it might move into something like a major depressive disorder, which I believe is my next slide. Let's see here. I want to check something real quick. Oh, maybe it's not in here. Major depressive disorder is when you have is something more serious. So it would be, there's 9 different criteria for major depressive disorder, and you have to meet 5 of those criteria. And that can range from something like mild symptoms, moderate symptoms, or severe symptoms. So if it's very similar to adjustment disorder, but if there's a higher risk for suicidality or other physical changes like low appetite or difficulty sleeping, that would be something maybe more indicative of major depressive disorder. For post-stroke depression specifically, this is one of the most common mental health diagnoses after a stroke. It does occur in about 20 to 30% of folks. Like I said, it is a little bit more serious. So it's a more intense depressed mood, more fatigue, sometimes more chronic pain goes along with that. Changes in the sleep and appetite. So that can be both spectrums. So that can be having trouble falling and staying asleep and not really sleeping very well at all, or the opposite, where you're sleeping too much or sleeping the majority of the day. And with appetite, it can be where you have a poor appetite and not eating a lot, and you might actually be losing weight due to that. And it can be the opposite, where you're overeating and you're actually starting to see increased weight gain from that. Post-stroke depression can also incorporate feelings of guilt or worthlessness, hopelessness or helplessness, all of which kind of stand for different things. And then also an increased rate of suicidality. So that can be something like increased rates of what I would consider self-harming behaviors. That can be like trying to, or burning yourself or cutting yourself, having suicidal ideations where you're thinking about killing yourself, or actually having a suicide attempt of some kind where you tried to kill yourself. So suicidality incorporates kind of a broad category there. And post-stroke depression can develop shortly after a stroke. So sometimes I've seen folks in the outpatient clinic, when I used to work outpatient, that were still having difficulties with depression years after their stroke. And, so it can occur right after stroke or later in their recovery, like 3 or maybe 5 years afterwards. This depression can be caused by the stroke itself due to neurochemical changes from that stroke, or it can be a reaction to those deficits following a stroke, or sometimes even a combination of both of those things. So this can be treated with antidepressant medication, which a lot of times for our stroke patients in the hospital, the physicians will prescribe an antidepressant medicine, or what's called a SSRI, or a selective serotonin reuptake inhibitor, that actually helps not only with mood, but it actually helps with motor recovery for folks after a stroke. So it's actually kind of nice because it tackles 2 different things. So it can be treated with that. It can be treated with psychotherapy, like what I do. And I'll talk a little bit more about what kinds of psychotherapy help. But research actually shows that a combination of both medication and psychotherapy is the best bet. So, trying to get best of both worlds is what I always try and encourage my patients to do. Other diagnostic criteria for post-stroke depression is there's a couple of actual screeners that we give folks. So we do 2 different types of depression screens, and we ask people, have they lost interest or pleasure in almost all of their activities that they like to do? So if I know a patient really likes to knit or garden or cook or fish, whatever those things or those hobbies might be, if someone's telling me that they have absolutely no interest in doing them, that's a red flag for me, right? That if the things that you got enjoyment from in life before don't bring you enjoyment now, I'd be a little bit worried about that. Another condition could be if this depression isn't due to another medical condition, or it's not explained by another mental disorder, if it does not occur exclusively during the course of a delirium. So delirium in the hospital can be when folks can become really confused, such as forgetting like the date or where they're at. They might see things that aren't there in the hospital or hear things that aren't there in the hospital. They might have acute personality changes while they're in the hospital. That would be delirium. So post-stroke depression would fit more of the criteria if it doesn't occur exclusively during that delirium episode. And then another criteria would be if this depression doesn't, or if it causes clinical distress in, like I said, social, occupational, or other areas of functioning, such as, their ability to parent or be a caregiver maybe for their parents, for example.
I don't know, what's this doing? What's he doing?
Another concern that folks might have is what's called a pseudobulbar affect. And this is called reflex crying. So this is when you can have rapid mood changes, such as suddenly starting to cry and then abruptly stopping, or laughing, for example. Like if someone is, if you're talking to them about maybe something particularly sad, and then all of a sudden folks start laughing, and that's inconsistent with what I'm talking about, or it's inappropriate at the time I'm talking about it, that can be reflex crying. So the example I sometimes give is when I might be talking to a patient about a significant loss in their life, like a loss of a spouse or a loss of a child, and all of a sudden they start laughing, for example. That would be inconsistent with the context of what I'm discussing. And so that might be something like reflex crying. This can occur in about 17% of stroke survivors, so it is fairly common, but it can decrease to about half of that percentage over time. So it is pretty high after stroke, but folks can get better with that over time. And a lot of times that's treated with medication. Oh, here's my major depressive disorder. I forgot the order I had my slides in. I'll leave these up there for a little bit so you can kind of see what I was talking about, but or maybe talk about some of the things I didn't mention. There, like I said, there are 9 different criteria, and to meet criteria to have this diagnosis, you'd have to have 5 of these things. So some of the things I didn't talk about were psychomotor agitation and retardation at number 5. That's where if folks are speaking or moving slower to the point where other people notice that they're moving or speaking slower, or the opposite, where folks are maybe more talkative, more physically restless, and folks start to notice that would fit that criteria. Lots of fatigue or loss of energy. So folks who will say that they are just too tired to get out of bed, and they never get out of bed for days at a time, that would be something that fits that criteria. And then also, I don't think I really mentioned number 8. If folks have a really hard time concentrating, or they have a hard time paying attention or making decisions, it can be really hard to focus on things in life when you're feeling really depressed or really anxious. So, and it can be hard to make decisions. So that's another criteria I wanted to add there. I want to talk a little bit about how these symptoms can overlap and how it can be hard to kind of sometimes piece out what is due to stroke versus what is due to depression. So as you see on this Venn diagram, some of the stroke symptoms can be different communication problems, mobility problems, or vision problems, and depression Our more serious changes, such as like thoughts of suicide, weight changes, changes in appetite, but a majority of these symptoms can really overlap. So the fatigue, loss of interest, sleep changes, difficulty focusing, some of these things can be due to changes in the brain itself, you know? So depression can be treated with medicine to help change your chemicals in your brain, and stroke obviously impacts your brain. So when you have those changes, you can have a lot of the same symptoms that overlap. So one of the things that I do in the hospital is I'll go in and I'll talk to folks about, you know, what symptoms they are experiencing and kind of pinpoint what might be related to stroke versus what might be related to feeling some depression. How can we help on both fronts? So what do the different kind of treatments look like? From an intervention standpoint, I really start to encourage my patients to do routine blood pressure checks because many of the strokes or most of the strokes are due to hypertension. And so I want folks to, you know, really try and check their blood pressure. If they don't have a blood pressure cuff at home, I'll encourage them to go to the pharmacy and use, sometimes they have, I don't know how they do it now with COVID, but, you know, they used to have that, like kind of, they have a blood pressure cuff that you can kind of check outside the pharmacies of like grocery stores. We'll do different kinds of psychotherapy. So I'll do CBT or cognitive behavioral therapy for chronic pain. I'll do that for depression. And what cognitive behavioral therapy incorporates is both the cognitive things that people tell themselves, like I am worthless, or I can't amount to anything. Like what are the thoughts we tell ourselves? And then behaviorally, what do we do? Do we have this thought and then we stay in bed all day? Do we decide not to eat that day? You know, what behaviorally are we doing? And then how does that impact our mood? Does that help us or hurt us over the long term in terms of how we're emotionally feeling? So we break all of that down and see how folks are coping. And then some of the treatments we do within that are mindfulness exercises or relaxing exercises, different behavioral modifications like adding exercise to their day. And that could be something like walking down to the mailbox and back. And then cognitive restructuring. And this is when we look at those thoughts, those unhelpful thoughts, and try to maybe challenge those thoughts a little bit or reframe them in a way to where they're more positive rather than negative, for example. Other interventions I do is diabetes management for folks. So, you know, lots of ways of managing that could be looking at what you're doing for exercise. What are you doing in terms of like your diet, and how are you incorporating maybe a diabetes healthy or friendly diet to your life, and how can we make some of those changes? Because sometimes those can be incredibly hard when, you know, all of a sudden people are saying you have to really watch your carbs, or you have to watch your sugars, or you have to watch your salt, and you know, that changes up how you cook, how you order things at a restaurant, and that can be challenging. So we talk to folks about how to help make that transition. For smoking, you know, like I said, smoking increases the rate of, or the risk for stroke by twice as, what's the word I'm looking for? You're twice as likely to get a stroke or have a stroke if you smoke. So if folks are wanting to try and quit smoking, we can come up with strategies to help them quit. I've worked with people about, you know, changing up their behavioral surroundings to maybe decrease the temptation for a cigarette. Like if they only smoke when they are like right after a meal, and they like more of the tactile reason for a cigarette and not necessarily the smoking it itself. I've had a patient before that took like a straw and cut it in half and just had a straw that was about that big and just kind of kept it in their hand to fidget with it rather than actually smoking anything. So coming up with alternative strategies like that can sometimes help in decreasing whether or not folks decide to smoke. Behavior modification, I talked about a little bit. And then the Plus Be Smart is a goal strategy that I work with folks to come up with how they can come up with achievable goals. So the SMART part is coming up with goals that are specific, measurable, achievable, realistic, and have a certain time length to it. And then the plus letter B is making it sound more positive. So starting off the goal with something like, I will walk down to my mailbox twice a day, Monday, Wednesday, and Friday this week. So you can see how specific that is. That is, I'm going to walk down to my mailbox and back, and I plan on doing it 3 times this week. So it's something that's realistic, right? You're not saying that you're going to do it every single day, but maybe 3 times in a week. And you give yourself kind of a time limit. You're saying, I'm going to try and do it for just this week, for example, and see how I do. And we can get really creative with not only the patient, but sometimes the patient's family, and creating some of these goals with them. In terms of screening, not only doing some of the routine blood pressure checks, but there are some psychological problems that can occur in children who experience a stroke. So there's different, mood screenings and behavioral screenings that that can be specific for children. I don't really work with children and adolescents, so I can't really speak to what is done here at the hospital for that, but I know that they would monitor that pretty closely. And then there is a needs assessment screener that can be given to parents to help to determine different follow-up services for children. That can be like different psychotherapy, different maybe financial counselors that we get on board, or like support groups, for example. And I think there's one more slide here. Yeah. So the one thing I also wanted to add to was the American Stroke Fund Association had put together this 5-part podcast. Wow, that was hard to say. 5-part podcast that focuses on COVID-19 and its impact on stroke. And it can be used both for patients and their caregivers. So I believe each episode, I want to say, is close to maybe an hour. And I listed the episodes here so you could see what the content of each episode was, in case maybe you didn't want to watch all 5 or listen to all 5. But I think it's great because it talks about, how has COVID-19 impacted folks who've experienced a stroke, and they're trying to do interventions at home, or they're trying to stay emotionally healthy or well at home when they can't maybe get out as much, or they can't utilize their social support groups as much anymore. Like this, for example, we're having to meet over Zoom rather than in person because of COVID-19. So you can really kind of miss out on that social connectedness, not only with people generally, but people who have gone through something similar to you. So I really liked this series, and I wanted to make sure that folks knew that was available to them if they wanted to watch it. So I have the website for this in the references section that I believe is on the next slide. But if you guys have any questions about that, please let me know. And I think that is it, Miss Sarah. Yeah, that's it. And that's very small font. So if folks want that maybe split into 2 different slides, I'd be happy to do that, because I realize that that's a lot of references, and I'm actually going to add a couple. So if folks need that split into 2 slides in a bigger font, let me know, and I can definitely do that. So